All, this is Dr. Mubin Sayed from Drbeen.com. Welcome to one more show. Today is my favorite day. We would have our chat. We will have our one-on-one. So let us start our open forum. So first of all, let's go through some of the Cool Bean updates. And Shahida, walaikum assalam. So there is a question from Quat Ladi. Hi, Dr. Bean, please talk more about your experience with prophylactic supplements and case severity. Definitely, I can do that. Also, whatever you can tell us about treatment of post-COVID syndrome, I can talk about that, and vaccines. Okay. So Quat, at a later time during this discussion, you'll have to remind me of these things once more, because these points are going to be scrolling up and I would forget them. So I would definitely do it. I just would need a reminder a little later. Good morning, Siddhartha. And let us start. So the very first thing, so this is Drbeen.com. We have our Cyber Month sale going on at this time. So if you click on the check plans, you can see the discounted prices. This is our Twitter thread for which I will be responding to the questions. And then here are the links to various things. So various questions that are asked, either they had the links or I had found some links to answer the questions. So all those links are here, plus the links are in the description as well. Now let's very quickly look at the Cool Bean updates. Couple of updates that are very interesting. One update is for a Cool Bean, his father. So this particular Cool Bean is not a doctor. Most of the time, the patients that reach out, most of them are doctors and their family members have some issue, or they are medical students, because that is the circle that knows me more. And most of the time I can then talk with them to figure out what is going on. This particular case, the person is actually an engineer, and his father has the COVID-19. And what is interesting in my observation from the doctors become very concerned when they see the labs going up and down and the oxygen levels going up and down. But this person, he was not very concerned, and he had brought in, I think the doctor had put his father on Delta Cortril and then Azithromax and another couple of antibiotics. So from the day one, and I feel that starting Delta Cortril from the day one actually causes harm, because the patient just keeps becoming unstable again and again. I think that is because the virus does not go away easily, because the immunosuppression is occurring. So about a week later, another team member of mine, who was a friend of this person, asked him to reach out to me. So he reached out, and what worried me was that his father's oxygen saturation had dropped to 88, 89 by the time they started talking with me. So I asked them that what are the oxygen saturations and others, and he said oxygen saturation 88, respiratory rate somewhere about 29, and I became really concerned. And I said, what has your doctor said? And he said, doctor had given us this prescription. We are at home. We are just giving him these medicines. So 3 days ago, I started him on ivermectin. So now this person is, in my opinion, he was going down, and he had sent me this P levels in dimers, and all of them were going up. So I started ivermectin with vitamin D, my general cocktail that I do, 3 days ago. And this morning, and I made him a little sensitized as well to the oxygen levels. And I said, this is not good level. He needs to start doing prone positioning as well. So once he was sensitive, he then started looking at the oxygen saturations as well. This morning, he sent me a very good note saying that my father's oxygen saturation has gone back up to 92, 93. He's feeling much better as well. He is walking around as well. And it looks like everything just has become okay. And this is how quickly ivermectin starts working. So I was impressed by the speed of recovery. And before that, I was worried by the rapidity of deterioration that I was seeing as they were sending me data about their father. So that is one. The second is John's dad. So John's dad is still in ICU on ventilator. However, his parameters, all of the inflammatory parameters, are actually going downwards. He has been on ventilator, I believe, now 3 days. And he is moving towards a point where they were saying that we would now start weaning him off of the ventilator, and hopefully in a few days they would take him off of it. So fingers crossed. Please pray for him as well. I'm praying for him as well. I'm talking with John every day. They have still not given him ivermectin. They simply say that this is not approved, so we cannot do it. And so they are doing dexamethasone and remdesivir type things. I think they have agreed to give him vitamins and other supplements. For example, Dr. Paul Marrick's protocol, they are giving him oral high-dose ascorbic acid, and I believe some other pieces from the Marrick protocol as well. However, they have not been using ivermectin. They're just reluctant to it. So these are the couple of cool bean updates. Now let's start looking at the questions. So first of all here, this is Marista Dershe, wishing you and your family happy Thanksgiving. So thank you very much, and happy Thanksgiving to everyone. Thank you very much for giving me a day off yesterday. We enjoyed it. We didn't go anywhere. We didn't invite anyone. We had a nice, quiet Thanksgiving. We didn't even go out for lots of groceries because I think the time, we are in Santa Clara County, where I think it is a hotbed at this time in California. So we just stayed put, and just whatever was at home, we enjoyed it together. James Bruno, why was this tweet labeled as possibly offensive and not displayed unless drilled? So this happened. Some of my tweets have been labeled as possibly offensive, and when you open it, it's nothing. So that's just Twitter. Camille Soares, thoughts on Dr. Yerdan's video in regards to PCR. I did not watch this video yet, and so can't comment on it. What is happening is that many times the videos links that I'm getting, some of those are kind of too much on a radical conspiratorial side, and it becomes a waste of time to go over them. So I have been avoiding 5G like videos, but there is some truth about the PCR not being as accurate, and we know it. We would talk about that maybe at a later time. Jonathan Loon says, hi, King Bean, just drawing your attention to this excellent meta-analysis site for ivermectin. So here is that site, and I love it. Thank you, Jonathan, for doing this. This is the meta-analysis. So meta-analysis means that what they've done is they've taken all the studies about ivermectin, and there is another meta-analysis for hydroxychloroquine as well that I would show you. They've taken all the studies about ivermectin, put them together, and then said that if we wanted this many positive results randomly, then the chances of getting those results is here. P is 0.000, so I think 1 in probably 10 million. And so they put their analysis on top, which I really love, and say early treatment is most successful. And then 100% of the 8 randomized controlled trials report positive effects. And then what they've done is they've gone down here and actually talked about every study. So look at this. Early treatment. So this is ivermectin. They have a similar page for hydroxychloroquine as well. I believe here is that page. So I don't want to confuse them too. At this time, let's look at the ivermectin. So early treatment, number of studies reporting positive results, 3. Total number of studies, 3. Percentage of studies, 100%. And then for probability of an equal or greater percentage of positive results from an ineffective treatment. For example, if you're just giving something, placebo, 0.13, 1 in 8. So 1 in 4,000, 1 in 4, 1 in 4, 1 in 524. So that is the kind of studies they've put together and done meta-analysis. So this is a good site. Thank you very much, Jonathan, for sharing it. We know that ivermectin is doing very well. So then next is Tommy. Can COVID cause long-term premature ventricular contractions? If you think steroids can help them, what kind of course pill should I take? to my doctor, about? So the first thing is I have this little study here. So COVID-19 and cardiac arrhythmias, a global perspective on arrhythmia characteristic and management strategies. So here they have done an analysis in which they say that it is actually possible to observe arrhythmias. And arrhythmia mean any duration or frequency or rhythm change in heart's beating. So there can be atrial arrhythmia, that is on the atrial part of the heart, and there are ventricular arrhythmias for the ventricular. There are suprajunctional, there are types of arrhythmias. So to answer your question, they have observed arrhythmias. However, they say that a lot of such patients who were having arrhythmias were also taking hydroxychloroquine and azithromycin. So to be able to say that this was really COVID-19 or this was the drugs, that is the confusing factor. Having said that, whenever something would cause damage to heart, that can cause arrhythmia. And in case of COVID, damage to heart is not just very straightforward. It is not that if I get COVID today and I have mild symptoms, my heart has to be damaged. It normally would occur when the virus has invaded the bloodstream, it is present in the blood, then it finds a chance to connect with the endothelium or the inner lining of the vascular system, then it goes to the conduction system of the heart and then makes that system abnormal. Or if the virus causes enough electrolyte imbalances that the cardiac arrhythmias occur, or the virus causes enough vascular damage in the heart that arrhythmias occur, or it causes enough heart damage, the tissue damage, that arrhythmias occur, and I haven't seen it. And now let me add a point here. Many folks comment after listening to these kind of comments from me, and they put a comment that what about people who have died and of COVID, and we have seen the virus to be in their brain and in their heart and in their testes and in their other tissues. And I have explained it before as well, I'll say it again. When a person dies of COVID, the reason that they die is the septic shock. Septic shock means that the virus has actually invaded throughout the body and the blood vessels have become dilated and they have become porous, and the virus was able to get out, which it would not normally be able to get in or out of those vessels, and has gone to the tissues where it would not normally be able to go. But that is an extreme case. The person has died. So another healthy person who gets mild or moderate symptoms will not have the virus cross the blood-brain barrier or go into the heart or go into the testes and so on. So please keep that in mind when you're thinking about where the virus can go. So with this, the second part of your question, if you think steroids can help them, what kind of course or pills? So if somebody has premature ventricular contraction, that is a ventricular beat which is occurring before the time of the beat, then first you have to get the workup done to understand what kind of conduction or tissue abnormality is present before you take steroids. Steroids will not help it. We'll have to see the conduction abnormalities reason. Based on that reason, they can give you specific drugs that would respond. Yes, if you suspect that the virus is still there or you are in a long hauling state, then steroids can be useful. And Medrol pack, if you talk with your doctor, Medrol pack, they can talk about it, or a simple pulse of steroids. So that is this question. Let me go to the live side and see what is happening here. How is everyone here? I love you guys. Thank you very much for giving me a day off yesterday. I hope you had a great Thanksgiving. I know these are somber times, but whatever happiness and relaxation we can get, we should. So let's start on the live side here. So Quad, good evening. Barbara Warren says, hello from North Carolina. Welcome, Barbara. Muhammad says, hello, welcome. Samudra Gupta, COVID vaccine, the front runners and difficulties in storage and distribution. So, Samudra, I have actually done a couple of discussions specifically on the vaccines, especially, for example, Pfizer's vaccine needs minus 70 degrees centigrades, and the Moderna's normal refrigeration, Oxford's normal refrigeration. But Pfizer says that they have specific boxes or containers that would keep the vaccine at the right temperature when the container is filled with dry ice. And it can keep that at that temperature for 15 days. So I think that is doable. And then in addition to that, they have thermometers in the containers that are reporting to Pfizer at all time for the temperature inside the container. Plus they have GPS attached to the containers as well. So they know all the time when they are being transported where the container is and what is the temperature of it. So they can very well tell you if the vaccine may have gone bad or not. So they say that logistically they have a control over it. So I would not be too much concerned about it. So for me, the front runners are Moderna, Pfizer, and Oxford. Sinovac is something that I'm waiting for. They haven't released the results yet. They say they have found good efficacy, but they haven't released the results. So once we have the results, we'll see what is going on. William Day says, how do they compute logical doses? Perhaps count the number of TMPRSS2 molecule in the body and make that many molecules of bromhexin to match. They can do that, but most of the time they start experimenting with cells in a petri dish and see what dose would cause the cell to die and what minimum dose would cause the effect not to appear at all. From there, they would kind of assess that, all right, this is the kind of dose range. Then they would go to animals and then they give them smaller doses and higher doses and see the responses. From there, then they come to human trials. So most of this is science in the beginning and then testing on animals and then humans. Kelly, thank you very much. Yes, I had a great Thanksgiving. Thank you very much. And I hope you had a great Thanksgiving as well. Margaret McInnes, good evening. Thank you very much. And Margaret, once again, thank you very much for your generous support. William Day says, would the amount of bromhexin be able to find the target TMP? Seems like the pill would need to be a big one. No, so again, the current dose of bromhexin has been showing effect. The problem is for bromhexin, the studies are still equally good and bad. So some studies say it don't do anything and some say it does. So I think it is not related to the dose yet. It seems to be something else with bromhexin. Ken Kaplan says, question, does Dr. Marek have any statistics from his clinical work as to success of his eye mask protocol? So I think he just started the ivermectin. I think in my heart of heart that he had watched my video as well on ivermectin. And from there, his thinking process started, because a few days after my video, the title of the video was Ivermectin Works. He had asked me that, can I use a slide from your video to include in my video? So I think it is too early for him to declare the data. He does have some stats for Math Plus, but I think he'll have some data soon for iMask. And I have no problem, Dr. Marek, using that information, because even I read it in the studies and then present them to you. I'm not doing that research by myself. Even then it would have been okay. Margaret, hello to you as well. Palm West, good evening. Good evening from Tennessee. Laura, God bless you doing this. Thank you very much. Laura, I'm happy to do it. Joe, Dr. Bean, in your opinion, how long do you think you need to be exposed to COVID to be symptomatic? WHO says, and CDC and FDA, as much as we can trust them, they say closed environment exposure for 15 minutes. That means outside exposure may have to be longer if at all it's going to do something. But inside, for example, a doctor's clinic or a hospital, 15 minutes of exposure without any protection can bring in enough viral load to cause an issue. Very good question here from player unknown. Lung fibrosis associated with COVID-19 is reversible or reversible or irreversible? So let me very quickly answer this question. It has been asked a few times. So let's look at it. Imagine this is an alveoli, and alveoli has type 2 pneumocytes, and then it has type 1 pneumocytes, and then it has macrophages and many other cells. Around the alveoli, alveolus here, one alveolus, is the tissue, the connective tissue. And then around, next to the connective tissue, is the blood vessel or capillary. Correct? So this is the structure, the smallest unit in the lung. Now, when we talk about pneumonia, so instead of saying fibrosis, I'm going to start with pneumonia. When we talk about pneumonia, what we are talking about is congestion in the alveolus. Here, this is called typical pneumonia, in which inside the alveolus, there is fluid and debris and pus accumulation. Then if it happens outside, which happens most of the cases in the viral stages or viral infections, that is called atypical pneumonia. The COVID-19 is such an powerful virus that it first starts with the atypical pneumonia, and we would have wanted it to just stay that way, but then it becomes typical as well by invading and destroying the cells and coming into the alveolus as well. So because of this, the fibrosis and scarring and the damage can occur outside the alveoli and inside the alveoli. Now, what we normally say is that this pneumonia or this damage here can have multiple outcomes. One outcome is a resolution. Resolution would mean that whatever is here has become resolved. It has gone away and the repair has occurred and we are back to normal. That is one outcome. And in a majority of the people, that is what is happening. The second outcome is organizations. And organization happens, there is a red hepatization, then gray hepatization, and then organization. What does that mean? What happens is that inside here, bleeding starts because these things start breaking down. The blood in this congested area would make it look red, and it would look like a jelly or liver-like thing. So that is why we call it red hepatization. Then the red blood cells that have come in here, they would start breaking down and their hemoglobin would start breaking down, and this thing would become gray in its color. And that is what we call gray hepatization. And then finally, there would be fibrosis that would occur here. And the fibrosis would simply mean now there is scarring and the fibroblast has given some tissue here, and this is the fibrosis. If we have reached a point of fibrosis, if you, just like in your question, you say, is fibrosis fixable or not? Most of the time, fibrosis cannot go away because that is scarring. There is some fibrosis that can be reversed in early stages, but majority of the time, if fibrosis has occurred, patient's tissue has reached a point of scarring. And if that scar has occurred here, this tissue would never become functional again. You can do physiotherapy to open up as much as from this tissue. You can do physiotherapy to open more parts of the lungs and so on. But usually fibrosis means irreversibility. This is what is called baby lung physiology, which happens with COVID-19 and other respiratory problems as well. So good question. Let's continue. Joe says, hi, Dr. Mubin, here, back to you, Joe. John says, corticosteroids from day one. Yeah, so that is a problem that in some countries, they have learned that giving steroids and azithromycin, they've removed the hydroxychloroquine thing. They give zinc, azithromycin, and steroids, and that's what they do, and they send the patient home. What I'm seeing is that it still works because steroids from the day one, I think my suspicion is that steroids from the day one keep the immune system controlled. It doesn't become a runaway train, but it also causes the patient not to recover as elegantly, and the patient just keeps bumping around the issue of the virus not going away. When I treat someone, I do not give steroid in the early phase. I take a few days, and in those few days, I am very aggressive to look at the oxygen saturations. So in those first few days, I continue to give vitamin D and vitamin C and melatonin and calcium and magnesium and copper and zinc and quercetin. And then I also add ivermectin. And then if I see that they still have some respiratory outcome, which is, for example, shortness of breath, then I start the steroids. My unfortunate for me is most of the time I'm called in when the cases are becoming troublesome or they're declining, and doctors have already given steroid from the day one, and the person is already just bumping along, and then they call me and they say, what do we do? The patient is not stabilizing. And so then I have to come in, and it becomes tough. It is call every hour and figure out what's happening and what are the numbers, and then adjust and prone position and steroid and ivermectin. Fortunate for us that we've been lucky. David G says, question, how risky is transmission from food, Dr. Bean? Depends upon the amount of the virus. Generally, this virus is not transmitted through the food. But imagine if somebody, I'm going to give a gross extreme case. Somebody has the virus in the mouth and they have spit in the food. So of course, gross and extreme case, but just to make a point. Now, if that spit has enough volume and we have taken that into our mouth, then it can actually cause an issue. Same is the case for the snot as well. So the question, I think, if I refine your question further to say, if somebody touched their nose and then they touch the food they're making and then they bring the food to you, just like staphylococcal infections or food toxicities, would that cause the virus to be dangerous? I think those minor touches will not. But at the same time, we have been talking about the surfaces. So I think surface or food, the important thing is the amount of virus that is present there. That, if it is in right quantity, it would cause infection. If not, then not. E-Dog, welcome. Good day from midday sun, Queensland, all cool beans. Good day to you as well. SNC Nutrition, thank you very much. So let's see more questions here. Marie has a question. Sorry if you already answered this question, but how does one find a local US doctor who will prescribe ivermectin? So I think it is funny that somebody else has asked me the same question, and in my text, I sent them a link. So why not I do this? I would put the link out right now for, I have retweeted them as well. There's an online telehealth company who say that we are open to giving ivermectin, but we still have to have a contact with you. We still have to take your history. We still have to figure out if ivermectin can be given or not. But if it is indicated, we will give it. So Marie, please remind me a little later. I would tweet their address once again. So my Twitter is, if you see here, _ let me take this out for a second. Here is my Twitter account at @Drbeen_medical. So if you can go there after the video, after this talk, I would tweet their address. So France, welcome. Yes, Luffy today is quiet. I think he would take a few more minutes to start chiming in. Laura says, I'm getting sicker, having trouble getting ivermectin anywhere. Then the online doctor said it doesn't treat COVID. I'm a long hauler. Laura, I would treat the link where the online doctors are saying that we are open to prescribing ivermectin. Plus, for long hauling, steroids are also important. So I would tweet the link. Please talk with them and see if they can help you. Marie says, my doctor says he's opposed to ivermectin because it is not benign. It can cause neurological illness. Comment. So very rarely. So I actually thought that this question would come up. So I have a book open here on my Kindle. See, it says Mubin's Kindle, Goodman and Gilman. Goodman and Gilman is the God of Medicine book, one of the best books. And if you see here in the adverse effects, ivermectin is well tolerated by uninfected humans. In filarial infection, ivermectin therapy frequently causes a Mazotti-like reaction to dying microfilaria because the worm is breaking down and it is dying and our immune system is reacting, and that can cause some damage to us as well. The intensity and nature of these reactions relate to microfilarial burden. Depends how many worms are dying and breaking down and releasing their antigen, and our immune system going nuts to kill them. After treatment of O. volvulus infection, these side effects usually are limited to mild itching and swollen tender lymph nodes. So keep in mind the very first statement, ivermectin is well tolerated by uninfected humans. So we are not infected. Most of us are not infected by worms. We are taking it for a different reason. So normally that worm breakdown and the issue related to that is not true for most of us. And then what they're saying is, so now look, these side effect. So after treating a worm, the side effect that could be tender lymph nodes, which occur in 5 to 35% of people, last just a few days and are relieved by aspirin and antihistamine. Rarely, more severe reactions that occur that include high fever, rarely, he has said, tachycardia, hypotension, dizziness, headache, myalgia, arthralgia, diarrhea, and facial and peripheral edema. Rarely. But look at this. These may respond to glucocorticoid therapy. So give steroids and these would go away. Ivermectin induces milder side effects than does DEC, and unlike DEC, ivermectin seldom exacerbates ocular lesions on psoriasis. The drug can cause rare but serious side effect, occasionally resulting in permanent disability and encephalopathies in patients. And I was talking with someone where they said that they have not seen it happening in a long time. Excuse me. So, and this permanent disability and encephalopathies in patients with heavy L-LOA microfilaria. So that is if the patient has a big burden of worms, and then you give ivermectin, which goes and breaks down the worm, and now the broken worm is spread in the body, and the immune system is just responding and killing and going nuts, then some side effects appear. So I wanted to bring the book in, so now they can actually send me a letter to say remove our book for copyright reasons. But still, I think it is important for us to see from a good source to understand what kind of side effects can occur. So please read this once more. The drug can cause rare but serious side effect, occasionally resulting in permanent disability and encephalopathies in patients with heavy L-LOA microfilaria. So in patients of the worm. So going back here, let me go back here and then back here. So I hope, Marie, that answers that question. For a doctor to use the word it is not benign is actually not the best way to describe this drug. It is one of the safest drugs. And causing neurological illness, yes, if you have that microfilaria and you have a huge burden of it. Jim John says, yeah, they're now bashing with. They think that the rest of the world is mad, and we are trying to figure out ways to just appease ourselves and be psychologically better. And in that process, we are abusing ourselves by these stupid vitamins and the drugs. There are studies that have significance, statistical significance, to show that there are results. So have they forgotten their own science that they use to approve things? Okay, so continuing on. Hamid Naeem Khatak says, can ivermectin be repeated to an asymptomatic patient who is persistently testing PCR positive? Yes, it can be. But I would also suggest to figure out, is the test kit not right, or what is the reason for repeated positive? Is the patient immunocompromised? Is the patient in a carrier state? Or is the test too sensitive? So check those things out as well before just giving the patient too much of ivermectin. It is studied that patients who have recovered and have PCR positive, they are usually not contagious because the RNA that they're throwing out is broken down. So there's a question from Joe. Dr. Bean, in your opinion, how long do you think you need to be exposed? So I answered that question a little bit before. Jem R says, for educational purposes only, I'm wondering if it is safe to obtain ivermectin from India online. So some people, Jem, had sent a comment that, hey, we got some ivermectin from India. So I hope that the companies are correct. I cannot vouch for the companies, but if somebody has sent good ivermectin and you have, let's say, prescription to get it, it should be fine. You're correct, MST Claire. France, you're absolutely correct. It is one of the safe essential medicine. That's correct. There's a question, Carlos Ortiz Monreal. Can you please comment on MMR vaccine being helpful for COVID? So I talked about it a few days ago that MMR vaccine seemed to be protective against COVID. What is the right mechanism is still not known, because MMR vaccine is given when you are very young. And then at a later stage, 30 years later, 40 years later, it is still protecting against the COVID. That is a wonderful part of it. But studies say it does help. Exact mechanism, they say it may be trained in immunity, it may be cross immunity. That mechanism is not known. David says, Jem, I ordered some from India. If I suddenly stop posting, you know the answer. I hope, David, that you stay safe and healthy. So, Marie, that your doctor is usually good, but he is prejudiced to anything. That is correct. But even FDA is doing a really bad job. The studies available are available. So the channels like ours, one thing that they have done as a service is to help people see how to find studies that are used by FDA approvals as well, and how to understand what those studies significance is, how to understand the numbers there. The FDA's, in addition to those studies, FDA has contacts, right? So if I am from Lilly or Johnson and Johnson, I would have so many contacts in the CDC and FDA, and I'll just call them up or send them an email and say, I want you to look at this, we have done this, and here's a study. So they have a direct channel which other researchers do not. But from a importance of some medicine or supplement and its statistical significance, the data that you see in the studies is a similar data that FDA sees. So we can look at those data as well and understand them. I thought that FDA should have a wing that is doing that all the time and then doing recommendations. They seem more fixed on other things. John Masleet has a good question. How can anyone predict the inoculation dose of the virus? How can anyone predict if one autoantibodies to one's own useful antiviral interval? Actually, who's treating early outpatient anyways? So yes, you're correct. The thing is, the amount of virus that is needed for various people is going to be varying. Some people would respond better, some people respond with asymptomatic, some mild, some moderate, and some don't respond at all, like children. So the dose is not going to be one specific dose for everyone. Okay, so this is what we have here. I'm going to go back to the Twitter for a second. So here, Terry says, why is the FDA not giving leronlimab EUA? Terry, that is a good question. I do not know why leronlimab, either it is not showing efficacy or they do not have the right channels to go and present their data. So even without approving leronlimab, FDA and CDCs are negligent in so many other ways. Donald French says, is there such a thing as a good virus? Will my steps to block virus replication have negative consequences because good viruses, if any, will also not replicate? Very few. There are good bacteria, very few good viruses. So don't worry about that. You stop their replication. And normally good viruses or bacteria, when even you kill them out, usually they regenerate and they inoculate us once again. There is sometimes cases when we have taken the good community out and that causes the bad community to take hold, and then we get symptoms, especially in the GIT infections. When we give antibiotics, that kills the good bacteria as well, and then GIT has a problem. So here is another. Paul Wolf says, the CDC now estimates 53 million Americans were infected by September 30th, 8 times the number of confirmed cases at the time. Of those, 45 million were sick at some point, and about 2.4 million were hospitalized. Can we estimate or test the number of those 53 million who have memory cells? The source of those numbers is USA Today article. Whatever the true figures are, the question is basically what percent of the US public has herd immunity? Paul, very good question. The best way to do that is something that Sweden had done. After they suspected that we would achieve herd immunity, they would stand on the roads or go in the communities and do random antibody tests, and then see how many people have developed tests, and then extrapolate that onto the whole community. Although I've done this discussion in the past as well, just testing the antibodies is not sufficient in case of COVID-19, because there are some people, for example, children, who would respond to this virus through their innate arm without developing a lots of antibodies. Then there are some people who would respond with the cytotoxic arm, that is a CD8 T cells, without having a lot of B cell activity. So if we are going to really understand the herd immunity's level, then we would have to test for antibodies, we would have to test for innate arms strength, and we would have to test for cytotoxic T cells that have memory against this virus. So all of these cells or cellular communities, we would have to test them, that are they reacting strongly to COVID? Then we can really say what is the herd immunity. Sweden's testing did not reveal the right percentage of herd immunity, so they just gave up on that for further testing. So to shorten my answer for you, do not know what is the right way to tell if we have what is the herd immunity level, because we don't have the right tests yet. Donald French says, will the prophylactics step I am taking, so I think this is two-part question. Donald French says, since March, I take 800 milligram per day of quercetin and 50 milligram of zinc, slightly higher than what Dr. Zelenko says. He says 500 milligram of quercetin. Last month, I obtained hydroxychloroquine, and I'm following Dr. Zelenko's prophylaxis. As a 74-year-old male, I am a high-risk patient or person. Will the prophylactic step I'm taking for COVID also protect me from other viruses? Does the benefit apply to all viruses? Does my COVID-19 prophylaxis obviate the necessity for a flu shot? Flu shot should be taken, just so that we can take one more thing out of the equation. Now, this is a very interesting question that you're asking. Today, I was talking with a cool bean over the phone. His name is Tom. And we were talking about the same thing, that the prophylaxis that is given, not just for the SARS-CoV-2, it is actually useful for other viruses as well, and even bacteria too, because in general, other than directly attacking the virus, for example, zinc attacks the RDRP. That is for any virus that has RDRP. Other than that, we are actually strengthening our immune system. We are strengthening our epithelial cells. We are strengthening the bonds between the cells. We are strengthening the membrane stability of the cells. We are strengthening a cell to be able to release the interferon when needed. And so that protects us against other infectious agents as well. Luke Henry says, what do you think about the beta blockers as a potential treatment? So here is the link about the beta blockers. And what I saw was somebody has given a hypothesis. Hypothesis is the following. They are saying that beta blockers, which are given for hypertension, they're saying that beta blockers are able to modulate interferons downward, and they are able to modulate immune system cells downward, and they are able to modulate the reactive oxygen species behavior downwards. All of these are protective. The question in my mind is that how protective for COVID, because there are, in my opinion, better medicines or supplements that can do these things. So do we have to give beta blocker because these have effect on heart and blood pressure as well? Not everyone should be given beta blockers. Beta blockers are a serious thing to do. So as much as there is a good hypothesis, and I'm sure that there is a research that backs that up, if I have to modulate my T helper cells, I wouldn't do that with beta blockers. I would do that with other meds. Similarly, if I have to block, release interferon, I would rather give ivermectin to do that instead of a beta blocker. So yes, beta blocker may be useful. Question is, do you want to use beta blocker because of its effect on hypertension and heart? I can say if this theory hypothesis is good, then those who are taking beta blocker may be further protected, and that is a good thing. So one more question here, and then I'll come back to the live side. So Roshan says, could addition of famotidine and bromhexine be beneficial in the iMask Plus protocol? Absolutely, Roshan. And there are actually more things that could be in there as well. But I think Dr. Marek tries to have the smallest number of things that can be useful, and then you can add on other things as well. So yes, your question, famotidine for sure. Bromhexine is still up in the air. Now on the live side, how is everyone doing here? Even in the question answer session, I missed the chance of interacting with everyone. I'm mostly just looking at questions and answering. So liquid smooth, this is the point I was discussing with Tom today. So liquid smooth says, I normally get sick 4 times a year. I haven't been sick since January, but I also added vitamins D, zinc, quercetin, C to my diet. I changed things out of fear of COVID. I was talking with Tom today, and I was saying, To me, people are saying that winter is going to be really bad. I actually think that winter may be better than previous winters. And the reason is, number one, people are social distancing. They're trying to protect themselves and others. Or let me say majority of the people. People are more careful for sanitation. People are more careful for hygiene. More people are taking supplements. More people are concerned about their immune system's proper behavior. That these positive things are not just SARS-CoV-2, but they are going to map to other viruses and flu and common cold as well. So if I could hypothesize, I would say that these healthy behaviors and supplements would actually help during the winter to keep us away from other things as well, or protected from other things too. So very good point. So please do me a favor. If you have a question, put the question or Q or question mark, something that I can identify and look at the message. So Shahida says, why not ivermectin prophylaxis along with supplements? Yeah, so that is what I expect. That if we are doing ivermectin prophylaxis, we are also going to do supplements too. So Xylon Papuga, I don't know if this is a question or comment. I agree with your comment that people who have had COVID and are fine and they have antibodies, they don't need the vaccine. Okay, so just looking at the word question. Okay, so it seems like, so here is a question from Rakesh. Rakesh says, now feeling fine, my tests are not near normal. When should antibodies test be done? So if you have recovered, you should actually get your antibodies. I always say to get antibodies early, because antibodies would go in a decline later on, because the memory cells are going to stop functioning and the active cells are going to stop functioning as well until you get the exposure again. So before the declines occur, get the antibodies test done so you're comfortable that you have become seroconverted. O08 KLM says, apparent increased rate of new cases, is it related to the people mink population new strain spread or what? Very simple. It is the number of cases already present. So see, when one person was infected, they infected 2.5 to 3, and then they infected 2.5 to 3. Now we have so many cases that in a single day they infect a bunch of other people. So it's not just that the virus has become weak, or it is not just that the winter has arrived, or it is not just that there is some other thing, for example mutations. It is really the number of people who have it. So if imagine this, one person in Wuhan had the virus, and within 10-11 months the whole world has it. Imagine now 10 million have it, or 20 million or 30 million, and how many people they would make sick. So that is just the number of infected people in the society. So Terry David has a good question. Dr. Bean, are children being treated with ivermectin for COVID or just adults? Most of the time, ivermectin is actually given to children for worms. It is the children in some of the poorer countries who have worms, and they are given ivermectin. The contraindication is ivermectin to anyone below the age of 2 years, because their blood-brain barrier is still being developed, or below the weight of 15 kilogram. Don't give them ivermectin. Similarly, don't give ivermectin to pregnant women although some people say it is safe, but I do not do it. And then do not give ivermectin to a lactating woman either, because it is not known if ivermectin can cross or go through the milk to the child. So anyone bigger than that, 150 to 200 microgram per kilogram body weight is the dose. Again, use it with your doctor's advice. So SunkissedAdrift, I like your name, SunkissedAdrift. Asymptomatic COVID patients, are they considered contagious or not? I keep hearing debates surrounding this. Very simple answer. The transmission of infection depends upon somebody talking, sneezing, laughing, or propelling the vapors with enough force that they can go to someone else, or touching their saliva or snot and then touching surfaces and leaving the virus there. That is one. Second, asymptomatic has two stages. There are people who are asymptomatic when they get the infection. In that, there are two stages as well. Those who would stay asymptomatic and those who would be asymptomatic for first 3, 4, 5 days, then they would develop the symptoms. And then when they recover, they'll become asymptomatic and they still would have virus for some days. So in all of those cases, that means there is a category of asymptomatic. That which asymptomatic are we talking about? Let's talk about children being asymptomatic. Are they contagious and would they transmit? Yes. Children would have asymptomatic infection. They would still have viable pathogen in their mouth and nose, and they would be spreading that around. Then they would recover, but in this whole process, they would stay asymptomatic. So that means in the early part of asymptoms, no symptoms, they're contagious. In the later part of no symptoms, they're not contagious. Let's take adults. Those adults who have just become infected and now they're going to stay asymptomatic for, let's say, 3 or 4 days. 5th day, for our example here, they became symptomatic. The study says that they would be contagious for 2 days before the symptoms. Why 2 days before the symptoms? Because they are on, let's say, 5 days before they got the virus. The virus is now slowly increasing in number in their system. But this virus has not increased enough in number to cause symptoms. But 2 days before, the virus load has increased enough that they, when they talk or laugh or sneeze, they are transmitting it. So that means asymptomatic adults, 2 days before their symptoms, are usually infectious or contagious. Now let's talk about those asymptomatic who would be asymptomatic, who are adults and who would stay asymptomatic. For example, they are handling the virus through their CD8 cells. Same mechanism for them as well. The 2 days before the symptoms, which they would never get, but 2 days before that mild botheration, they would be contagious. Then their body would take care of the things. So now let's talk about asymptomatic who have recovered. So I had symptoms, now I recovered, and now I do not have symptoms. By definition, we don't call the removal of the symptoms as asymptomatic. We call that recovery. So those who are in recovery also do not have symptoms, but they're also not contagious because what they're throwing out now is a broken virus, and that would not cause infection. So the debate is out there because asymptomatic needs classification and which asymptomatic we're talking about. So one person raises their hand and says asymptomatic would not be contagious, and that is true. The first 3 days you would not be contagious. Another person raises their hand and says asymptomatic will be contagious, and that is true because 2 days before the symptoms you are contagious. So it really just depends upon what stage of asymptom we are talking about. I hope that answers that question. So Amreen Uzma says, Dr. Bean, what to take in Sweden? Do you have ivermectin over there? If not, at least vitamin C, vitamin D, melatonin, famotidine, quercetin, zinc, CoQ10, NAC. These are the things that one must take. Okay, so what else? So Anthony Karalika's question, thoughts on MTHFR methylation issues predisposing to poor outcome or long hauling. Methylation vital for viral response and elevated homocysteine, prone to vascular and neuro problems. I have been trying to do two discussions as separate topics. One is the testicular involvement, because it seems that many men are concerned about their fertility and the post-COVID issues. And second is the long haulers and possible mechanisms to treat. So Anthony, if you are okay, would you allow me to take this up as a separate topic? Okay. All right, so I'm gonna go to so there is one more question here, actually multiple questions here near the bottom. Let me answer a couple of questions, then I'll go to Twitter. One question is from Saeed Hushiar. Question, should ivermectin be taken on empty stomach and what time of the day? It doesn't matter. Ivermectin's interaction with the food or absorption issue with the food is not present. So you can take it on empty stomach if you like. What time of the day? Anytime. When sometimes patients call me and they say that here is our patient who is in a bad state, I ask them if the pharmacies are open, run to the pharmacy, get the drug and start right now. So I've never cared for the day. I usually give 6 milligram with a 12-hour interval. Many of my friends that have heard ivermectin from me and then they've started practicing it, they give the first day 12 milligram stat and then they give in divided doses. So I hope that answers your question. Ari Bowman says, how effective is the RT-PCR test in detecting the SARS-CoV-2 virus, and what is the risk that any non-viable strands or structure of any corona could signal positive COVID-19? So Ari, I have done a detailed discussion about positive predictive value and negative predictive value and RT-PCR. How true is this? So I've done 2 or 3 studies about this in talks. Generally, the right way to look at it is to look at the sensitivity and specificity of a test kit. And all of them have different sensitivity and specificity, slightly variable. Second part to look at, an FDA site has all the test kits that are approved, their parameters present. The second part is, what is the smallest RNA number of fragments available that they can then amplify? Third thing for RT-PCR to note is the cycle threshold, that we are using 40 as a normal threshold, but that some people say is big enough that even small fragments that would not be viable or not be able to cause too much of a disease and would be taken care of by our immune system, they still appear as infection. So that is one part of it. The second part of your question, that is it possible that the non-viable broken down segments could cause RT-PCR to be positive? Yes. I have a different problem. I had a patient who clearly had COVID. His chest CT showed COVID-based changes as well. And he did RT-PCR thrice and it came back negative 3 times. His wife developed COVID as well, and her RT-PCR came positive the very first day. So RT-PCR does have a strange behavior, but these data points should help us understand about a specific kit. Raza says, any thoughts on high eosinophil counts appearing in long haulers? Mast cell activation, what is the link between high eosinophils and high immunoglobulin A? Good question. So normally eosinophils are responsible to attack worms. Worms are taken care of by eosinophils. And in that process, IgE is more important because IgE will go and attach to the worm, and then IgE would coat the mast cells as well. And then eosinophils would come in and become triggered with the IgE plus the antigens of the worm, and then they would attack it. Now, I haven't seen in long haulers the eosinophilia. So, Raza, it may be interesting if you can talk with me on Twitter and talk about the labs where which long hauling state have you seen eosinophilia and how commonly? Um, 008 KLM. What is the current R percent? Are you talking about R naught for the COVID-19? I think it still is 2.5 to 3. It hasn't exceeded 3, but even 2.5 to 3 is sufficient to just massively increase the numbers. Gaurav Shah says, question, I had asymptomatic COVID-19 3.5 months back. How likely am I to get it again? Should I go for vaccination? Ideally, you would not. If you didn't have the symptoms before, that means your body was able to respond to it in a way that you didn't even know, and it fought it off. So, as long as your health status has not changed, your immune system status has not changed, ideally you should be fine. Still, if you wanted to go take a vaccine that doesn't make any problems, that is fine. You can take the vaccine. But generally, if you have the body ready to respond, then you don't need the vaccine. Wayne T says, Dr. Bean, what vaccine will you be taking? So, very good question. One of my friends from my country of origin has been visiting US for last 3-4 days. And he is with another friend of mine who's a doctor, I believe, in Michigan. He's a radiologist there. So they both were together, and they called me this morning. And so they asked me the same question. They said, well, Dr. Bean, you keep talking about these things. So tell us, which vaccine would you take? And I said to them was that I would take messenger RNA vaccine over traditional vaccine. And they both kind of became a little surprised, and they said that, why would you take an mRNA vaccine? It's a new type. And my answer was that if you look at side effects, they have a similar type of side effects. But if you look at the vaccine's packaging and delivery, this vaccine doesn't need to have a lot of other things in it, adjuvants in it, or other substances in it. It is a liposomal packet with the mRNA in it. And that liposomal packet is better than an adenovirus because it doesn't have other antigenic properties of the adenovirus. It is a package in which there is messenger RNA, and that package enters our cell and gives the messenger RNA, and we make spike protein and we start defending or learning to defend. So if I was given a choice, I would go for messenger RNA over the traditional RNA. That's one. Second, we just saw that the traditional vaccine had lower efficacy compared to messenger RNA vaccines. Both of messenger RNA vaccines reported 95% accurate efficacy, and the traditional vaccine 62%, 90%, average 70%. That's just weird. And I'm still waiting on CoronaVac, or what is that? The Sinovac vaccine. I think it is called CoronaVac. Once we have some data from there, that is also traditional. We'll see what else are traditional vaccines doing. I would prefer an mRNA vaccine. CP Joshi says, can early ivermectin hamper immunity building for COVID-19? What is minimum required infection duration for immunity building? Beautiful question. And I think, Joshi, you would be happy with the answer. So let's look at the answer. Look, first thing to keep in mind is that ivermectin is not an antiviral, right? So what ivermectin does is the following. Here is a cell, and then if the ivermectin is present, I made that ivermectin man a few days ago. So if ivermectin is present, it would cause the nucleus to continue to release interferons, which would allow the neighboring cells. I had made some cute cells that had their defensive swords up and that were totally happy to defend themselves, right? So again, this is not an antiviral. So that means the question that you're asking, that hey, how long before the virus or during the virus can we give ivermectin? If you have given it on the day 0, or if the ivermectin was always present in our body, then when the virus arrives, virus will not have a chance to dysregulate or damage too much, because our cells will be able to fight with the virus much better. So that means ivermectin's presence is actually appreciated right in the beginning. Golmukh has a question. Dr. Bean, still planning to look at Nigella? Yes, I am so sorry. So effect on testis, that is one. RT-PCR is another. Nigella sativa is another. I keep taking notes for these, and then something new comes up. Like last week, vaccines were coming up, and then I start doing those. So yes, absolutely. Question. There is a question here. Matthias Becerra. Question. What do you think of the ones who don't believe in the existence of COVID-19? Proclaiming that it's just a vitamin B1 deficiency or an every year common flu. How would you contrast this? So I have been coming across this a lot. To me, sometimes when I am on some TV interview and I'm looking at the comments on the side, people are actually cursing me, saying you are doing propaganda and you are talking about something that is a hoax, or something that Bill Gates is doing to, I don't know, get money from people, or inject microchips in people. So far, the way I have kept my head straight is that I simply ignore them. I don't even try to debate with them, because I know that the debates which I've seen, they usually degrade into or deteriorate into a cursing match, and you suck, and that is what starts happening. And I do not have enough emotional energy to start debating and then becoming heartburnt or cause someone else to be hurt. So I have just ignored them. Of course, they are incorrect, they are wrong. There are people who are dying. I think there was one time I became very upset with someone who was claiming that there is no virus. And I said, why don't you guys who are saying there are no virus, why don't you go and work in the wards? Become janitors there, become the patient handlers there, and you take the risk if you think that there is no virus. But again, I would not wish this on anyone, even if they are saying it is a hoax. So there was just once that I lost my temper, but generally I ignore them and I wish them well. Valerie Road says, question, Dr. Mubin, will you treat a cool bean by telemedicine? Not in the US. So I don't practice here, so I can't do it in the US, but I do manage folks over phone. Matthias, that was a good question. So Nadir Tarani, question, Dr. Bean, could a SARS-CoV-2 mutation, such as what we are seeing in Denmark with the cluster 5 mutation, we talked about it, the minks, cause a second or twin pandemic, render any vaccine developed for the current strain ineffective? Yes and yes. So yes and yes, it is possible. The question, so WHO is warning I discussed it in detail. Their warning had a couple of critical things and a flaw. The critical thing was that they said we are seeing mutation in the spike protein. That is worrisome. If the SARS-CoV-2 changes its spike protein in a way to continue to bind with us, our cells, maybe in some other way or with an altered spike protein, that would render our existing immunity and vaccines ineffective. If the spike protein has become changed enough. And let me explain what do I mean by that. So I know that there is upper part of the screen available. So let me do that. So imagine this is the spike protein's pattern here, which an antibody's binding site recognizes. And that antibody may be created because of a vaccine or an infection. So let's say this is the antibody's binding site. This is the SARS-CoV-2's spike protein. Now imagine if I got infected, I have this antibody available. If the SARS-CoV-2 arrives in my body, I would take care of it because my antibodies can recognize the spike protein and attack it. Now imagine SARS-CoV-2 becomes cute on us through the minks and becomes this way, that their spike protein now is structured this way, let's say. So the binding site is still fine, but this area which was being recognized by our antibodies has changed significantly. Now this area cannot be bound to our antibody. May that be produced, that antibody, because of the vaccine or because of our prior infection. That means we will become sitting ducks once again, and it can cause the issue again. Examples: SARS-CoV-1 to SARS-CoV-2. There is a mutation. It's the same coronavirus. So those who were protected from SARS-CoV-1, there are studies that say they still have cross-protectivity, but not enough. Similarly, MERS-CoV and the SARS-CoV-2, those who have MERS-CoV or who have had MERS-CoV, and now they have SARS-CoV-2, they are not protective. So similarly, if the new mink-based mutation comes in, that would be called SARS-CoV-3. And that SARS-CoV-3 may not properly be protected by the antibodies produced in us. It would be very fortunate of us that if we still are able to. So can it cause another pandemic? Yes. Can it render vaccines and previous immunity useless? Yes. I would also then go to the flip side and say, is it possible that mutation is only enough that there is some changes, but the spike protein is still the same? So no more pandemic and no other issues? Possible. But World Health Organization had said that in cluster 5, the mutations are in the spike protein. That means the virus might end up getting selected, which has enough changes that it can escape our existing mechanism that after dying and misery and locking down the world, we are developing. And then it would just escape them again. So that is a worrisome thing. Why I was upset with WHO on this one point was they had said, and I discussed it, they had said, no need to have any travel restriction. We have just asked them to kill or they're planning to kill the minks, so no worries. This is the same thing they did with with Wuhan as well. And here we are. So I hope it doesn't happen. We cannot afford another new pandemic superimposed on this pandemic. It would be devastating. So Jean Payton says, Dr. Merrick is a senior member of the ICU teams at hospitals and SE Virginia. Has he been able to get the GPs in that system to adopt the IMAS Plus protocol in their daily practice? What he has been saying is that in his hospital, they have been using Math Plus. I'm sure that they're using IMAS Plus as well. But good question, I'll ask him actually. I had, if Nina can't from Twitter, if she's listening, she wanted to send him masks, so I contacted him today. I would ask him about this question too. Here is Luffy. 008 KLM, would an mRNA vaccine for spike mutation be quicker to develop than original vaccine? Of course. So now it would be fine. It would be quick for us to just keep adopting the vaccines and keep making the more monoclonal antibodies. So yes, probably if this happens again, we would be better prepared and we would have better platforms to respond, but it still will be a devastation. Carolyn RNA, sorry, Carolyn RN question, has there been any new development regarding MIS-C? Haven't heard of any cases in a long time. I'm wondering if it was truly related to COVID. That's a good question. I'll have to look it up because I haven't been seeing, maybe they're not labeling them as such. So Carolyn, good question. I would check it out. So before Sheikh Maniac, 1 second, Acoustic Theory has a comment. The minks were not rising. They were decomposing and body gas caused their bodies to move and they were able to pop above the surface. Oh, wow. Okay. That is some graphic description here, Acoustic Theory. Okay, so Sheikha Maniac. Question, what about all the Galectin research on COVID? Will you do an update on the latest? Sure, I would. So Vikram Chandwani, what is your take on remdesivir as per latest update? Remdesivir doesn't work. We knew it already. Interestingly, whichever patient has been calling me to become involved, they always have dexamethasone and remdesivir going. I usually do not go in and ask them to stop it. I continue that, but I always see renal profile and liver profile to be imbalanced. I think remdesivir at this time is riding the wave of dexamethasone and then things like ivermectin. Earl says, Bowman, I would like to believe that the spike protein could mutate enough where it fails to work. So Earl, that happens. In a person, when there is a infection by SARS-CoV-2, there are mutations that are happening even in one person, and then some generations of virus are created that cannot bind to the ACE2. This is just like some babies born that are disabled. And the problem is that these viruses that cannot bind to ACE2, they die in that person. So they don't have a chance to go out and spread because they cannot get into a cell, become more and so on. So hoping that all viruses would go away by the all SARS-CoV-2, they would not. Because the viable SARS-CoV-2 that can bind to the ACE receptors will continue to transmit until we all become safe by either infection or by herd immunity or by vaccination. So all of them. So this is the same question as I saw on the Twitter as well. Can ivermectin produce arrhythmia? So no, ivermectin ideally does not cause arrhythmia. You're welcome, Earl. Okay, so I'm going to go to the Twitter site for a second. GOK says, how strong is the evidence that the COVID-19 virus damages the testes? And so I would do a complete topic about that. This is a study. So men out there, please don't get worried yet. So testicular pain as an unusual presentation of COVID-19, a brief review of SARS-CoV-2 and the testis. So I'll talk more about it. Men, please, actually, whoever is interested in healthy testis, please, everyone should be. So stay put. I would do a talk about it. Donald French, Is there any downside to continue using quercetin while I take the prophylactic dose of hydroxychloroquine? Ideally, no. If taking hydroxychloroquine and quercetin is reasonably safe for COVID-19 prophylaxis, can I add 400 milligram per day of EGCG to the mix? Is there a downside? So there are, of course, some downsides to the quercetin itself, but the problem is EGCG is a zinc ionophore, but it does not behave like quercetin, and because of that, adding EGCG is not bad. What it will do is it would just add one. It is one more ionophore for zinc that would be there. So it is fine, but I would not recommend adding more quercetin because quercetin does have some side effects that we don't want. So the 500 milligram quercetin with 50 milligram zinc is sufficient. If you wanted to add EGCG, that is fine as well, but doing it over is not useful. Brooklyn B. Northrop says, I'm a long hauler with monoclonal gammopathy of undefined significance. A band of monoclonal IgA lambda is seen. It is thought to be an immune response and benign. Could this be COVID related and treatable with ivermectin? And if so, at what dose? So the thing is this, ivermectin's primary behavior is anti-inflammatory in COVID and promoting the interferon. Both of those behaviors help modulate the immune system. So if you said that should I take ivermectin as a long hauler, there is a benefit of that. But the question is, does that benefit rise to the level of steroids? So both of those, steroids or the ivermectin, they both can be tried together or separately. This, I am really sorry that this long hauling situation is becoming bad. Every week I decide that this whole week I would spend time on only the long haulers, and then some news comes in, something that becomes important, and I talk about it. We should talk in detail about the mechanisms of long hauling and what can be helping it. Jonathan Loon says, can you comment on this paper studying ivermectin in SARS-CoV-2 infected hamsters, reducing tumor necrosis factor alpha, interferon gamma, IL-6, what is causing IL-10 levels to rise? So I have that paper over here. And I talked about it a couple of days ago, Jonathan, about the ivermectin's anti-inflammatory behavior, including suppression of IL-10, which can actually become bad. But because the overall balance is present, because of that, it is fine. So can you please watch my video on ivermectin that I did before this lecture? James Bruno says, thoughts on this study theorizing a fat-dependent ketogenic state encouraging better immune response. Very good study. I love this one. The dark side of the spoon. The name is nice as well. So the basic idea they are saying is, if our body is in an inflammatory state, then anything that would cause more inflammation or anything that would have the inflammatory system attack it can make our body unhealthy. And for sure, carbohydrates are pro-inflammatory. They are pro-inflammatory because they bring in a lots of energy, and that energy needs to be processed. And when that glycolysis is done, when that process is done, a lots of reactive oxygen species are produced, which then cause damage to us. Now add COVID-19 on top of it, and then COVID-19 can tip that pro-inflammatory state and cause even more damage. So this is the case for all of us. We all take bread, or majority of us, or rice or other things. Then they are proposing that if you take ketogenic diet during this time, then you have less carbohydrates, less pro-inflammatory state, and you are in a better shape to handle the virus. And I agree with that. That is a correct approach. Heather says, I've looked online for that spray. So I think it's a two-part question. So Jaro Franta says, months ago, there used to be frequent discussion about prophylactics and what people choose to use. Maybe an update would be appropriate. I have been, so now you can see that how many topics are the ones that I plan, but then I keep having to talk about others. Prophylaxis is one more topic that I wanted to just sit down one day and only talk about prophylaxis. Excuse me. So good point, Jaro. For instance, are cool beans adopting carrageenan nasal spray as regular use, prophylactic, or just occasional use? So I would actually put that question to the cool beans. Tell me, do you use carrageenan? Do you use it regularly? Sometimes. Do you use any other nasal sprays? Do you use mouth washes? What kind of mouth washes? How frequently are you using? This is a curiosity for me as well. There is a cool bean. His name is Mike from San Jose, not in San Jose anymore. He's a retired surgeon. He had said to me was that, why not we start gathering this information and then gathering if people are becoming sick and see that with these supplements, what is the kind of benefit that we are offering? That is a good idea. So please tell me, give me a comment for how is it going. So Heather had responded to him. So I'm going to, Janet Elderton had this question. How common is ivermectin allergy? So Janet, I actually looked up everywhere for the incidence of ivermectin related allergy, and I didn't find the incidence numbers. So I cannot say how common. Secondly, as I just read the Goodman-Gilman, they say that most of the time the side effects are because the worm is present and that breaks down, and that can cause actually allergy-like behavior because the eosinophils in our body and mast cells, they would degranulate, they would attack the worm, and the broken worm would cause them, because there are more pieces to go around in the body now, that would trigger more cells, and then they would react, and that is a side effect. So I didn't see the actual incidence numbers. Karen Cross says, can red or infrared LED lights stimulate vitamin D? So Karen, your question that you are in an area where there is no sunlight or not much sunlight, I would suggest to use the UV lights. Is this possible to get the UV lamps? UV lamps are very common, or daylight lamps are very common, which have the ultraviolet rays that are useful for vitamin D production. So I have a link here that you can use. Again, the links that I put here, I have no association with them. I have no financial interest. I Google them, I read them, and the one that I feel has better content in there, I put them out here. Okay, so one more question here, and then I'm going to come onto the live side. Janet Elderton, my question about allergies to ivermectin. I assume that this warning is supplied for all medication. I could not find anything about, and that is correct. The allergies to ivermectin in Goodman-Gilman, they do not talk about allergy. Goodman-Gilman talks about side effects. So if you see here, from here is well tolerated in uninfected humans. Filarial infection, if you see here, they are talking about side effect as itching and swollen tender lymph nodes. So maybe that is what they're calling allergies. Or then they're talking about, and they may be calling this allergies because the relief is by aspirin and antihistamine. And that means the itching is happening because of histamine release, which can be called as allergy. But that is not an allergy to ivermectin. That is an allergy to the broken worm. Okay, so I'm going to go to the live side. Zelona Papuga, do you believe our life will return to normal? For some reason, I fear that new pandemics will come soon after the current one is resolved. I think we'll be back to normal. I was talking with someone who wanted to create a package of supplements for COVID, where they were saying if I could recommend some dosage, they can get those manufactured and we can offer them to cool beans. and the manufacturing time for all that can be 2 months. And I was saying that I think in 2-3 months with the vaccines, we would actually be forgetting COVID-19. And touch wood, I wish that to happen. And I was saying that cool beans would start forgetting me as well by that time, because we would not be talking about COVID-19. I'll go back to doing normal, regular medical lectures. And so not everyone will be interested. So things would calm down. So Xylona, as much as I would miss you all, and I would be sad to not have these interactions, I think that in next few months, the pandemic is start going to cool down. And I think the habits that we would have formed and the learning about the supplements and the scientific advancement that we would have had, any further changes or chances of pandemic, we would actually respond better. My friend, the two doctors I was talking about, when they called me this morning, they asked me this question as well. They said, so do you think that science has advanced? And I said, yes, we have advanced 10, 20 years in this 1 year. Yes, ignorance has advanced as well, but science has advanced a lot. So we would handle things better next time. We will quell them right in the beginning. I think we'll be better off. So don't be upset. Mark Vance says, so if I can get any doctor in Florida to prescribe ivermectin, why are we talking so much about it? So I know it may be a rhetorical question. Talking so much about it is important for our education, for our understanding that there are things out there that can be valuable and useful, and even for these doctors' education as well. So I think we should talk more about it. The dark it is, the more dark it is, the more light we should light up. So we should talk about it. I am just sorry that many doctors, and even here every day, there are people calling me and saying, I talk with my doctor, they simply make fun of you or the video or the ivermectin, or they give negative comments. So they don't want to even think about it. So that is unfortunately a problem with the scientific community at this time. Okay, so on the live side, I think you guys are running out of the questions, which is a good thing. I'm going to continue on here with the Twitter and quickly plow through them. So vaccines and those, value investor 411. Vaccines and those who have contracted, recovered from COVID, pre-screen, will we have data affect priority? So as I said before, vaccine is not needed for those who have already the disease, but it really depends upon you, your doctor, your level of the antibodies, any health changes, health status change between when you had the disease and the vaccine time, any immunosuppression occurred, any drugs that are suppressing. So I think it is case to case, but generally, if you already have antibodies, you don't need a vaccine to come and trigger the antibodies. Willow Desk says, does Moderna vaccine make sterilizing immunity? So Willow Desk, I did not understand the sterilizing immunity. If you're saying immunity in which the virus will not be able to spread, then yes, the answer is yes. That is the point of the vaccine. Carrie Lynn says, how difficult would it be to conduct such a study? So I think two-part question. Carrie Lynn says, is anyone conducting a retrospective study to document serum levels of vitamin C, magnesium, calcium, vitamin K? Very good question. Vitamin D, etc. in COVID patients. A connection between these blood levels and disease severity, ultimate outcome, might help predict or even prevent poor outcomes. How difficult would it be? So I think, so you have already answered that question. Getting access to hundreds of thousands of patient charts sounds like a nightmare. Not only that, Carolyn, these numbers are not being calculated. I believe that even vitamin D levels are not being measured. So something that you have not measured, you cannot do a retrospective study on that. So I guess the answer will be difficult, very difficult. Yagami's nutsack says, many thanks for answering my question from last forum. So Yagami, that seems like a joke again, because people enjoyed your name last time. So I think you wanted to bring up your name once more. So that's okay. Okay, so Ripi Varal says, could metformin help non-diabetics in early COVID treatment? Please explain. Yes. So the studies that I had discussed, they did not talk about metformin targeting only the diabetic patients. However, if you are not diabetic and if you're going to take metformin, please remember it can cause then a drop in glucose level. It doesn't cause hypoglycemia, but still, if you are taking drugs that are going to reduce sugar levels, that can be an issue. So don't take metformin without talking with your doctor, and then don't take it if you're healthy without continuing to look at your glucose level. This can cause severe problem. But to answer your question, yes, it can be taken by non-diabetic. Actually, there are so many studies that say that metformin in non-diabetics is very useful for many other things. So they are saying it would be an emerging drug in the future for many other many other diseases too. So this was an interesting one. Dr. Cole Summers sent this. Another poorly designed study on vitamin D that was referenced by routers and used to claim vitamin D ineffective. So here is that study. Here. Effect of vitamin D3 supplementation versus placebo on hospital length of stay. So in this study, they are saying that what we did was, look at the design. This is a multi-center, double-blind, randomized placebo-controlled trial conducted in 2 centers in Sao Paulo, Brazil. The trial included 240 hospitalized patients with severe COVID-19. The study was conducted from June 2 to that. But the question is severe COVID-19. Look, the problem is once you are at the severe level, many of the drugs, many of the supplements would start failing because there is so much damage and so much dysregulation that has occurred that to go back and put the pieces together becomes an issue. If I was the one designing the study, I would say design it, give people prophylactically vitamin Ds and all the necessary supplements, then see how many become ill, then see how many end up in the severe state. Or the second design will be take those patients who have mild symptoms, maybe in outpatient start them on vitamin D and then see if they would become moderate and severe. A third design could be take those patients who are in hospital admitted because of oxygen dysregulation, so their situation is not that bad yet, and start giving them high dose vitamin D and other supplements, and then see how many progress to severe. Giving it to severe kind of is not the right time. So what they did was, after giving it to severe, they said it doesn't do anything. So I think not the best study to waste time on. Routers, if they spent on it, so I have become, just like I'm not very much fan of politics or politicians. Similarly, I'm not a big fan of WHO, FDA, CDC after this current behavior. I'm also not a big fan of media. Media has caused so much damage and confusion because they want these sizzling things that they can put out and you would become attracted and you would go and look at it, and they just take advantage of your attention. So what to say about routers? Steven says, question, if a person of any age catches COVID and the doctor doesn't want to give any treatment, at what age do you suggest giving quercetin or green tea pills, zinc, vitamin D, and melatonin? Thank you. So I actually do this for everyone, younger age or advanced. The reason is I don't take a risk at all on my patients. There are doctors who say that, hey, below 40, the chances of death are less. So it is okay not to do too much. I just don't do it. I don't take even that risk with my patients. But generally 40 to 50 and above are the ones who must take these things. One more question here, and then I'll be on that side. Could ivermectin be part of a game changer for other viral infections, or would big pharma crush the idea? So, notwithstanding the big pharma, ivermectin is very, very useful. Big pharma, they are just unbelievable. How are you enjoying the winter? So here is the winter. I am enjoying it, but the thing is, I'm in California, so we don't have snow here. I used to live in Massachusetts for 13 years, and over there used to be a lot of snow and fun like this. Scott Robinson says, is ivermectin available by RX in every state? Are there ACQ-like restrictions on its availability? So mixture, it is available by prescription. It is a drug that is available, but there are so many weird taboos. Number one, doctors are not convinced, majority of them. And if they're convinced, then they get the explanations for why did they do it. This is Dick Roberts, and your comments on this analysis of hydroxychloroquine. So this one, so we're almost at the end of this side. So I'm going to come over here for a second, in a second. This is a hydroxychloroquine data. And they are saying, the blue box, they are saying that the studies that have reported it to be working good, if you collected all the data from those studies, and then if you wanted a chance to occur, you were giving placebo, and then just by chance end up with those studies, the chances of that is 1 in 910 billion. So I love this site's behavior, that they have done a lots of statistical analysis on the studies and then put that data together. So here what they're saying is hydroxychloroquine, early treatment, 100% effective, late treatment, 72.3% effective, and keep looking at the p-values. These are good. Pre-exposure prophylaxis, 78.6%, post-exposure prophylaxis, 100%, and all studies, 1 in 910 billion. So that is a good one. I love this. I believe in hydroxychloroquine. I know that Dr. Marek does not, but I believe in it. Hello, doctor. I want to ask about prophylaxis vitamins most recommended. Vitamin C, vitamin D, zinc, and quercetin. Are these mostly safe for long-term use? Saludos. So this is from Relo Hero. So all of these things in the right dose or needed dose are good because our body needs them, and they are part of the supplements that we need. In extra doses, some of them can become an issue. So my answer here will be vitamin C, D, zinc, quercetin, yeah, fine. As long as you are healthy and your dosage is not crazy about it, it is fine. No worries. So I'm going to just answer this one. Let's see how much more do we have here. A few. Let me answer this one. Buddha Jiva says, if a person taking ivermectin prophylaxis volunteers for phase 3 vaccine trials, it would be difficult to confirm the efficacy of vaccine. Could that be the reason behind FDA NHS not conducting large-scale ivermectin trials so that adequate vaccine volunteers can be recruited? If ivermectin becomes over-the-counter for prophylaxis, everyone would start taking it. That would lead to confounding results in vaccine efficacy trial. Your thoughts on this? So yes, so the hypothesis that you have is correct, but people are dying. When the vaccine would arrive, we can't say that between now and the vaccine, because we want to test the vaccine, let people die. That is wrong. We have a medicine that can help. There is no reason to behave this way because this goes against the Hippocratical oath that we took. So that should be the behavior of all medical organizations and medical personals. So your theory is correct, but this practice is wrong. Okay, so I'm going to look here. So good question, Jem. Can hydroxychloroquine and ivermectin be taken in correct dose together with doxy? I have been doing it. So I have not seen any bad effects. So my answer is yes. Of course, talk with your doctor. Embol, 60 nanogram per milliliter, 50 nanogram. Okay. Question by Shane. I thought we didn't want to take NSAIDs because they stopped prostaglandins, but ivermectin also does this. The way ivermectin helps with the prostaglandin, this was actually a question that day as well. First, the NSAID thing, the Brufen thing, was actually incorrect. That was just, I don't know why a French minister came up. I tweeted to him and I said, give me some proof, and he didn't respond. So that first conjecture was not supported. The second thing is, we don't want the immune system to become dysregulated. So it is important to start modulating it right in the beginning. Ivermectin has a benefit over NSAIDs, and that is not only it is modulating the inflammation, it is keeping the cells strong enough to combat the virus. So we are beating up the virus while we keep our system in balance. That is the magic it has. Denise Gore says, question, how long after taking single dose of ivermectin is it still actively working? So the half-life is about 18 hours. So that means therapeutic dose would be dropped after 18 hours. So M. St. Clair responded already, 16 to 20. So correct. Thank you. Nader says, I know you don't like politics, but please consider running for Senate. You've learned that we need more people who actually believe in science. We definitely need more people who believe in science. I was looking at the senators with that hearing about the early treatment. As much as they were trying to help, there is just so much lack of knowledge and then lack of belief that it's disappointing. Acoustic theory, you're correct. Routers are not your friends, neither are the doctors. Correct. Okay, so Meera Rohit says, if ivermectin has been taken in first week of COVID, can it be repeated later as anti-inflammatory if inflammation markers? Yes. So my own regime, again, don't do it without asking your doctor. When I feel that somebody has COVID, I start them on ivermectin 6 milligram in the morning, 6 in the evening for 5-6 days. They normally start responding within 2 to 3 days, but I give them for 5-6 days. Somebody who's in a long hauling state, I have been using steroids. It is very recently that I've started trying ivermectin. I would report back on my results, but can it be taken? Yes. Earl says, question, what about fasting for 3 to 5 days or more at any level of infection? The basic fundamental thing to consider is that we do not want to starve our immune system so so that it cannot work. That should not happen. So fasting, that intermittent fasting is fine as long as you have kept your immune system in balance, nourished and healthy. Xylona Papuga, what's that black half glove on Dr. Bean's hand? I've always wondered. So I have explained this in the past as well. I have a drawing thing here, correct? So this is Wacom Cintiq, and I use this pen to draw on it. And if I do not have the glove on, then my finger here can act as a drawing pen as well, or it can just hinder my hand from sliding smoothly on that screen. I go through a lot of pain to present these things. So wear this so that I can smoothly draw, and my hand can move on the screen smoothly. So it is really to move smoothly on the screen. For iPad, when I use that, this also helps me from not, the iPad can use finger as a pen as well. So when I'm using pen on iPad, this prevents my hand to act as a pen as well. Although iPad has good palm rejection, it can detect the palm and reject it, but just wearing this would allow less processing on the iPad side, that it doesn't have to detect it and doesn't have to reject it. So it is just that. Yes, so you're correct, E-Dog, about 60 nanogram per milliliter for vitamin D, if that was the discussion. Okay, so I'm going to go to the end. More question. Here. I saw some questions. I think they just rolled up. So Marie has a question. What is it about diabetes that makes the sufferer at high risk of a poor outcome from COVID infection? Marie, very good question. In diabetes, we call it a disease of poverty among abundance. So here is what happens in diabetes. So if I go here and I make a cell, so let's say this is a cell. This cell is very, very curious to figure out when would I get my energy, correct? And for the energy, what it needs is candy. The candy is glucose, right? So glucose is like the candy that is going to go into the cell, and the cell is going to use that to make energy, correct? So these are the energy bars that it would make, ATP. Now for the glucose to go into the cell, we need doors for the glucose. These doors are opened by insulin. Insulin comes and attaches here and causes the doors to open up, which allows the glucose to go in. That is how the cells get their glucose. In type 2 diabetes mellitus, what happens is insulin cannot work correctly with the door. Why does it not work correctly with the door? When the insulin attaches here, there is second messenger mechanisms that would end up opening the door. Those mechanisms are not working correctly most of the time because of obesity and other such free fatty acid issues. The result is that the door never opens and glucose never gets into the cell. So now glucose is present, actually present in larger amounts than needed. That is the abundance, but the cell cannot get it. That is the poverty, that the cell that needs to use that energy cannot get it inside the door, inside it to make energy. Now imagine if this cell was a macrophage. A macrophage is sitting here and saying, God, I need that candy, but my door for the candy is not going to open up. It's not going to come in, and I need to fight the infection. So I need energy and I don't have it. That is what happens. So what happens is all diabetics have repeated infections, especially uncontrolled. And then if they get infection, it becomes difficult to heal or control because their immune system doesn't have enough energy to function correctly. That is why diabetes does it. On Dr. Bean's site, I have done some diabetes lecture, which I'm very proud of. So if you like, take those as well. But good question, Marie. So there's a question by John Elderton. Question, I noticed that people taking warfarin must take care of to watch their INR if they take ivermectin. How much of this is a problem? I haven't heard of ivermectin dysregulating the warfarin's behavior, but that must be in the liver, that the cytochrome enzyme must be dysregulated. I cannot answer that without looking it up. So I would look it up. So let me just very quickly, it's 2 hours. Let me quickly respond to the Twitter side, and then we can see if we can close. Heather says, question, perhaps not about COVID directly. Sleep is a benefit to our health when adequate, while lack of sleep hurts our health. Do you have guidance? How can we have better sleep, especially during times of worry? Heather, I use sleep aid, and most of the time mine is either Tylenol PM or melatonin. Of course, doing exercises that would tire you enough to go to sleep is also useful. Drinking plenty of water, not right at the sleeping time because then you'll go and pee a lot, but early in the day, relaxing with yoga, watching something decent, good, and then learning to kind of box the tensions and put them on a side as well. Let me do a separate topic about sleep. I think this is a great topic and we all need to work with this. Robin O'Brien says, can you ask about long-term quercetin use? Kidney, also their contraindication with Loratadine. So here is the kidney. Ideally, quercetin is protective for kidney. So quercetin strongly inhibited the hypertension induced by L-NAME and prevented the renal hypertrophy, vascular lesions, and proteinuria, suggesting that this flavonoid also has a protective effect against renal injury caused by the chronic inhibition of NO. So that is one. And then that second is the Loratadine, and contraindication to Loratadine, that is another part of your question, include patients with documented hypersensitivity to the drug. That is a standard thing that we say for everything, or components of the formulation with strong contraindication in children under the age of 2 due to its antihistamine properties, which may cause CNS stimulation and seizures. So that is the Loratadine contraindications. Tom Poole says, some folks are fearful, but is there any real risk of what? For diabetics, how does, so we just talked about it. Atlas the Husky. We just talked about it. The problem with diabetes, not only just this much, that there is less energy. On top of that, this glucose that is hanging around, this glucose is now forcefully going to get connected with the protein that is called non-enzymatic glycation. So for example, let's say that this is an epithelial cell and it has its epithelia here, and the glucose just hangs around them and gets stuck with them. Now they cannot function correctly. So not only the cell cannot function because it is low in energy, it cannot function because glucose is just hanging with it. And so when glucose hangs with the endothelial cell in the blood vessel, it causes damage there. When it hangs in a lens, it causes the blurring of the eye vision. When it hangs into our cells, so what happens is glucose then enters some cells, for example, nerve myelin sheath, sits down in there, doesn't get broken down because our system is not able to have so much enzyme to break all that glucose. So more water comes in, that causes these things to swell up and then break. That causes blood vessels to break. That causes nerves to break. And so there are lots of damage that these things do. So not the glucose does. So it's not just that the immune system's energy level is low, the functional qualities are disrupted as well. So that is just Atlas the Husky, an additional comment. Avox Coffee Bean. This study implicates spot on chromosome 3 we inherited from Neanderthals in virus vulnerability. Very interesting one, and that is the last comment for today. The major genetic risk factor for severe COVID-19 is inherited from Neanderthals. So they say, very interestingly, that there is on chromosome 3, there is a genetic area which we inherited from Neanderthals that predisposes us to more severe COVID-19, and that gene or cluster of gene is present more in the South Asia and less in Europe. My counter to this, so this is interesting, my counter to this is that we are seeing a lot of cases and damage in Europe, in US as well. So it is an interesting one. Okay, so we are done with the Twitter. I'm going to look here for a couple of more questions. We are 5 minutes over 2 hours. So let's just answer those and then we close. Daniel says, what about patients with unknown COVID-19 status, complaining of myalgia, fatigue, impaired sensory function without breathing problems? It could be COVID, it could be some other virus, it could be other nutritional statuses, it could be some disease as well. So there are many differential diagnostic reasons for these complaints. So they should go to their doctor, get them checked up, do maybe RT-PCR as well, and then take maybe a pulse of steroid, take ivermectin, have supplements, and see if that helps. So Kunal says, so with diabetes, having insulin supplementation would help. How? So going back to this one, so when you give insulin, so when you offer insulin, then insulin, you increase the levels of insulin so much, because there are, so diabetes is a big topic. What happens is, imagine this is our pancreas. Pancreas's job is to make insulin, right? Now, in the beginning, all of us, our pancreases are making insulin. We have the glucose that comes in. Then based on the levels of glucose, pancreas decides to make a specific amount of insulin. That insulin goes to the peripheral tissue, causes the opens the doors, causes the glucose to get in. This glucose amount reduces, insulin amount reduces, everything is good. Now imagine we have peripheral tissue, this cell here that has become insulin resistant because its second messenger system is not working because of free fatty acids getting stuck in its machines. Now what would happen is, there is glucose that you've taken, carbohydrates that you've taken. They have asked the pancreas to make insulin. Pancreas did make insulin, but that insulin did not work correctly. So what happens is, that means that glucose levels stay high, which causes the pancreas to make even more insulin. Pancreas doesn't know that peripheral tissue is not responding. So it makes more insulin. That also doesn't work because this thing is not responding. Glucose level stays high, pancreas make more insulin. The result is we start burning out the pancreas. And if we do not control our diabetes, within 10-15 years, pancreas, all the beta cells that are making insulin are burnt out. Once they are burnt out, now we have two problems here. Number one, our peripheral tissue is already not responding. And number two, there is no insulin to respond to because the pancreas is burnt out. So now we have become insulin dependent, and we have to give so much insulin that we at least open some doors. With that, we have to say, reduce your weight, do exercises so that muscles can take up insulin, glucose. Exercising muscle can take up glucose without the need of insulin. This is why you ask the patients of diabetes to exercise, because then their muscles would work and they can take up glucose without any insulin need. And that would reduce the glucose levels, plus that would make their muscles strong, which is a good thing. So we give insulin, but we also reduce free fatty acids, for example, weight loss and other things, so that insulin resistance is reduced. If somebody stays insulin resistance, then eventually insulin would not do a lot of work, and the kidney failure, neurological failure, blood vessel failure, infections, respiratory diseases would become more common, and the person dies of that. So that is a good question, Kunal. I've tried to sum it up in a small piece of information. It's a very big topic. Cool. So I think this is what we have for today. Thank you so much. Thank you so much for staying with me for so long. Please like, subscribe, and share. Please share if you dare to share this long video. And if you wanted to support my work, there is a link in the description for the donations. So thank you very much, and I would see you tomorrow. Bye-bye.